Hello, I'm Dr. Jonathan Levine, host of Case Bites, where we unravel the complexities in dentistry from simple to complex cases from a treatment planning case presentation standpoint. Let's get started. Today we have Dr. Rick Roblee, orthodontist from Fayetteville, Arkansas, wrote the book on interdisciplinary dentistry for all of you reading books in 1995-96. He enjoys an amazing orthodontic and multi-specialty practice with his two sons, who are also in the orthodontic world. What a lucky guy, father and sons. Rick's been lecturing in dentistry for 30 years, president of the Academy of Aesthetic Dentistry. And if I had to tell you all of his accolades, we'll be here all night. The goal of this Case Bite series is to share the latest thinking with people like Dr. Rick Roblee, to showcases with a panel of experts in their individual disciplines so that we can collaborate in our practice with our own patients. So leading us off, Dr. Rick Roblee, take it away.
Well, thank you very much, Jonathan. That was a very gracious introduction. And I too am excited, and I appreciate Henry Schein opening up this forum, because I'll be honest with you, this is my favorite type of lecture. And, you know, I want to get my favorite environment is the study club environment, where it's not a one-way transfer of knowledge, it's a two-way, and we gain knowledge. That's why I love interdisciplinary therapy, because when you have a team of experts where everybody's on the same level and you throw good cases out there, it is the most powerful teaching and learning tool anywhere. And it's all problem-based learning. With all that being said, I have a case that I treated. It's been a while now. It's been about 8 years, but I think it's a good case to kind of throw some curveballs in there, because every case is quite unique. And, you know, this case is I think has a lot to do about where we're going in the future. And this is Lisa. She's 50 years old. And her chief concern is that she always wanted to have a prettier smile. How many patients do you hear say that? And she says, all my life, all I wanted was a prettier smile. Okay. But I've been told I need extraction therapy with orthodontics. I've been told I need orthognathic surgery. I've been told I need restorative dentistry and do veneers and a full mouth reconstruction. And that just sounds too aggressive for me. And then she goes, by the way, I have an event in 1 year that I need to be ready for, and I will not wear braces. And so this is welcome to modern times in dentistry. And this is where it's easy to be more of a hairdresser and try to appease the patient and do what you can do in a hurry, but not thinking about the long term. And I'll be honest with you, today, with everything available, ortho, perio, pros, the whole gamut, we don't have to do that anymore. We can treat ideally. And I think that's what this case is about. And so let's look at her, just going through her history. Dentally, she's insignificant. She's got amazing teeth. I don't know if she's had a restoration or not, except she has long-term TMD, and we have actually had her in orthotic for a long time. Otherwise, medical history, very negative, except she's reported several respiratory problems. She's a mouth breather, which is a major problem, in my opinion. And she's got chronic allergies. Other areas, she's got chronic fatigue. She's been battling all her life, depression, fibromyalgia, poor sleep, and wakes 4 to 5 times a night and has to go to the bathroom at least once. And if you're really treating from a comprehensive interdisciplinary perspective, you have to focus on that, because we're talking about quality of life, not just oral, but overall quality and now quantity of life. And so we need to be looking at these other areas. And since this topic and this whole series of case bites is about the interdisciplinary approach, I wholeheartedly agree with the way Jonathan kicked it off, and that now our interdisciplinary team has got to include our medical counterparts. And we need to be looking at improving not only the quality of the patient's lives through dentistry, but also the quantity, okay? Let's look at her radiographs routine. Look, see very minimal restorations, beautiful teeth, no significant dental therapy. But we start looking at her jaw joints, and we can see, number one, that she's had significant condylar remodeling. She's a heavy bruxer. She has myofascial pain. And this needs to be red lights of something's going on that is not within dentistry that we have to expand our knowledge about. And that's why we do with the CBCTs. We need to look at airway, and CBCT is a good way to look at that, even though this is a screening tool where it measures the absolute dimensions of the oral pharynx. But more importantly is the collapsibility. So this is nothing more than a screening tool. But what I know is that these problems are very much totally in line with her overall medical problems that she's been battling all her life. And so I see an opportunity to not only help her dentally, but help her medically. And so here's her initial photos. Let's just kind of break it down. Aesthetics, I'm going to do this quickly. And this case is a little bit complex. We look at her, we look up here in the upper right, and her lips in repose. She shows no incisor exposure. At 50 years of age, we know that she should be showing at least 1 millimeter of incisor exposure. But then we look at her smile, and look what we got going here. We look at the arc of smile. She's got a reverse arc of smile. She shows, too much gum tissue in the posterior. She has an anterior open bite and severely constricted arches, which is leading to severe scalloping of the tongue because there's not enough room for the tongue, which I also believe it causes her to have issues because the tongue has to go somewhere. It's a hydrostat muscle, and so it goes back into the airway, which coincides with her CBCT. And so let's look at her facially. First of all, look at her eyes. We always have to look at her eyes. She looks tired. She's got, mild shiners that she's covering up with makeup. And you can see her constricted arches. And we look at her facially, and, hopefully you can see that she has an increased lower face height and mild lip incompetency. But this is all a factor of growth and development. And we remember the lower face is not formed genetically. It's formed by soft tissue function or dysfunction. And she's been a mouth breather her entire life. And so if we look at the rule of thirds, you can see she's way too long. And sorry, that went up too far. But she is just way too long in this particular area. And so we need to look at her vertical dimension. And that's one reason why she has an anterior open bite besides the tongue. And so when we're looking at this case, we need to break things down into the elements of all the different components. And what I want to say is this is exactly what she looks like, a rendition software I use in my practice. But you can see that she has a posterior VME is exactly what she has, which rotates the jaw down and back, gives her that long lower face height, gives her significant lip incompetency. This is where we want to go. And this is why it's important to have an interdisciplinary team, because if you just throw braces or Invisalign on her, you can turn her from a posterior VME to a full-blown VME with excessive gummy smile. So that's not where we need to go. And so what we do is we break things down into the elements of the issues. And with modern dentistry and medicine, we can treat each one of these ideally. And don't have time to talk about this, but hopefully we will more in the future. And for each hard tissue there's different modalities that we can use to treat the hard tissue. And I'm not talking about just the dentition. What you have to remember is the dentition is the hardest and least malleable structure in the entire body. And we have these other issues, especially dentoalveolar, that are incredibly malleable. So we have to start working that more into our interdisciplinary treatment plans. And we're also looking now at skeletal expansion, which again, in the future, we'll talk more about. So here she is. Let's kind of break this down and look again. The constricted arches, the posterior VME, the insufficient, incisor exposure at rest, not enough room for her tongue, increased lower face height, very unesthetic arches. And so this is where we can do a differential diagnosis. And she said earlier that she's been told she needs to have teeth extracted because of her constrictions to move the teeth back, which I think is a compromised therapy. She's been told that she needs to intrude her posterior teeth, via orthognathic surgery, which I think is way over treating the skeletal component. And then she's also been told that she needs veneers to kind of cover things up in treating the least valuable structure in the body. And so I think this is a good time for the team to come in and let's kind of discuss what our options are realistically with somebody who wants to be done quick and refuses to wear braces.
So Dr. Roblee, are there any tools that you have where you can share with the patient or try to kind of visually depict how you can move the teeth with Invisalign, or let's say with clear aligners? Or is there a tool that you prefer to use to teach you what the tooth position would look like if you were to expand the arch?
Absolutely. We do DSD, digital smile design, and Christian's a good friend. I've known him for years. So yeah, so we tend to visualize that as much as possible and show them and educate them because they've been told so many different things. Okay, that's a very good question. The other area that we haven't really discussed is tying the medical with the dental. Okay, and this is so important. This patient is a poster child for Upper Airway Resistance Syndrome. Okay, she's been suffering for it for years. I'm a trained anthologist and have done gazillions of orthotics, everything else, and more. When I start hearing a patient with lifelong TMD problems, I'm looking for a more systemic type problem, and it almost invariably leads to an airway issue. And what I'm here to tell you is we are in the driver's seat for these type of problems. If you're looking just at obstructive sleep apnea, you totally missed the boat because that's at the end of the spectrum. The spectrum is from birth to upper age, and that's when obstructive sleep apnea kicks in, except in the most severe cases. If you want to change the quality and quantity of life, this is the type patient that you can do it on. Any feedback on that?
How do you facilitate speaking with their medical professionals?
Well, first of all, in this particular case, we don't have to because she doesn't have obstructive sleep apnea. Okay, and if I told her physician that she had upper airway resistance syndrome that I thought was leading to her chronic fatigue, her fibromyalgia, her depression, and all these other myalgias, they would say, we're too busy treating the people who are, roadkill already. And so this is totally out of their realm. Now, if she had obstructive sleep apnea that I was able to pick up on, the first thing I would do is send her to the sleep physician because that's a medical issue that we need to get medical coverage on, get them on a CPAP or an oral appliance, and then make it our goal to get them off of it, which we usually can do. Okay.
Rick, do you feel that in looking at the diagnostic clues of scalloped tongue, of narrow maxilla, no room for the tongue to reach that, nice relaxed, upper palate when at rest and swallowing, and mouth breathing, when we add all those things together and look at her fatigue and look at her medical history as dental professionals, and you as really, understand the orthodontic and the medical implications of all of this, how do we as clinicians and dentists take these diagnostic clues and help a person like this? Because I'm sure as you thought about expanding maxilla or creating space, that that there's going to be probably some wonderful opportunity for medical improvements.
Yes, that's a really good question. And this is really, virgin territory in a lot of different ways. And in a lot of ways, it's the wild, wild west out there. And, my recommendation to everyone is that if you're going to jump into this, do not even think about taking a course that's related to an appliance, okay? You don't want to take anything that's device related, because there are so many groups out there now that are educating and motivating dentists to do things for profit around an appliance, and they really don't understand the scope of things. And if you don't really understand the nature of this, I recommend you do not jump in until then. And so we have a whole gamut of different treatment modalities, treating the right components, working with our medical counterparts. And we don't talk about treating airway with oral appliances or CPAP. We're talking about treating the underlying problems and correcting them. And it takes an entire team of interdisciplinary therapists, it takes a medical, it takes myofunctional and other allied therapists to help you. And I don't want to make it sound overwhelming, because it's not. But we need to have you need to have a knowledge from A to Z to determine where the different treatment modalities fit in. Because I'm here to tell you, I know there is no magic one appliance that treats all this, no matter what you hear. But there's millions of dollars promoting that, and you need to be really concerned.
Right. That's a great watch out. So Rick, when you look at a case like this and you're visualizing where we can take it, can you show us your visualization tools, as Dr. Durham asked, like how do we see what's possible? And then, that whole concept of where do we want to go, and then how we're going to get there? What technique is going to get us there, which would now create a treatment plan from that visualized solution?
Okay, very good. Okay, her problem all along, and this is every generation we're getting smaller, our lower face, because what you have to remember is the lower face is not genetically driven. It is driven by soft tissue function and dysfunction. And so all her life, since she was a little girl, she's been a mouth breather with allergies and other things. And so when it comes to soft tissue function or dysfunction versus bone and teeth, soft tissue always wins. And so what's happened is, instead of having her tongue up against the top of her mouth 95% of the time, which develops it laterally, projects it forward, and keeps it vertical, she's had an open mouth posture, breathing through her mouth. So what happens? She constricts, she grows vertically and down and back, okay? And she is a classic example that you have to look, maybe some have to look closer, but that's what it is. And so we have to think, we missed our opportunity where we're now treating these cases at 3 years old and younger. We missed that opportunity. Now we have a grown adult. What can we do to reverse that process? And first and foremost, create the right structure and environment, and then treat the function and behavior. And the beautiful part about this is it's a perfect marriage between health and beauty, because we're going towards ideal in both. And so if you ask me which is the best treatment plan for her aesthetically, what's the best treatment plan for her airway, I will give you the same treatment, okay? And so, so the problem is she's constricted and she's got posterior V and an open bite, okay? And the other thing is we have to realize is that the reason she's this way is because of her function and habits. And we're not smart if we think we can correct structure and leave the soft tissue alone and function and expect it to be stable. So we have to do both. And so do you want me to go through what my proposed treatment?
That would be great, Rick, if you take us through your treatment plan and your visualization.
Okay. And, you look at all the aesthetic things that Jonathan, has outlined and stuff. There's really nothing she's lacking from a dental standpoint. Agreed? She's got beautiful teeth, great proportions, beautiful gingival tissues. It's just everything's rearranged. And if I look at her, what's the only two things that are semi in the right place in her face? It's her central incisors. And so we have to look at it. What components are involved here, and what control do we have to change the infrastructure? And, in my opinion, those two components are our two front teeth. They're in a good spot. If anything, we can extrude those a millimeter or two just to give her a hint of incisor exposure. But then we need to move everything else up. Can we do that? And can we do that conservatively without braces and without major surgery? And so what we're going to do is initial therapy, occlusal stabilization, to appease her, mild functional problems, get her muscles relaxed, get her condyles corticated. And if we need to, we might even do a trial oral appliance to make sure that our airway works. Next, we're going to create the volume in the function that's needed. And so definitive therapy, we're going to use clear aligner therapy. We're going to use surgically facilitated orthodontic therapy because clear aligners cannot intrude teeth. It can't torque teeth. It can't translate teeth because they can't overpower the resistance of the bone. And so instead of throwing the baby out with the bathwater, we say, okay, what can we do to change the resistance in the bone? And that's what we do. We can reduce the resistance in the bone by 50% with the wrap effect. And we don't have time to get too much into that. And we're going to use skeletal anchorage and elastics. It's that simple. And then long-term maintenance, no restorative in this case because she has virgin teeth, is orthodontic retention with just any type of retainer you want to, and myofunctional therapy to retrain her oral habits and routine dental and periodontal care for the rest of her life. Okay. This is after surgically facilitated therapy, showing the clear aligners, and all this is digitally driven. We do everything digital. We do digital smile design. We have all that. And here we have anchorage. You can see it's skeletal. We're going to be using elastics. We've reduced the resistance in the bone by 50%. And we're actually changing the relationship, which we call alveolar-skeletal changes. Dental-alveolar is moving teeth in the alveolar bone. Alveolar-skeletal is changing the dental-alveolar complex in the skeletal base. And so we're going to leave the front teeth where they are, extrude them about 1 millimeter maybe, and intrude all the other teeth and expand, which is going to give her greater oral volume tremendously and auto-rotate that mandible, which is going to open up her oral pharynx, especially at the angle of the mandible, allow the tongue to come forward. And so here she is initially, and here's a progress photograph. And look at the arch development that we attained. Looking at her smile, you can see we basically did exactly what we planned to do. The teeth are, extruded about 1 millimeter, which is going to be nice. But look at her arc of smile, according to Jonathan's, protocols, and you can see that the gingival display in the posterior is gone. But the oral volume is massively different. And every millimeter of volume change is a 4-fold increase in the airway. And how long do you think this took? 4 months. Okay.
I was going to go 6 months.
Okay, 4 months. And let's just go.
That's
forward.
amazing. So surgically facilitated orthodontic therapy reduced the bone resistance, allowed you to use clear aligners to create that intrusion of the posterior segment and create that overbite overjet relationship anteriorly.
And grow more bone and soft tissue where we could change the dental-alveolar complex on the skeletal base in a highly stable way. Instead of trying to force teeth where there's no alveolar bone and tissue, we're just growing more tissue and bone. Okay.
Rick, we're all wondering what happened to her medical condition.
Absolutely.
Did she go from a mouth breather to a nasal breather now that she has increased, nasal passages and a widening? Could you give us what happened medically?
Sure. This is after 4 months. And then we did a refinement to fine tune. You can see how much we reduced her vertical. Look at the width. Here she is 48 months later. Okay. Look at the volume, the beautiful soft tissues. And this is why treating the right fundamental components is so critically important. And look at that beautiful, gorgeous smile. Okay. And then facially, this is 6 years after this picture, basically 5 to 6 years. Look how much healthier she looks, younger she looks. Look at her eyes. She got off all her meds. She's sleeping through the night. She no longer has chronic fatigue. And when I asked her, a true story is I was going to present her case one time and I asked her permission. And she said, Dr. Roblee, you've changed my life so much that I want you to use my case however possible to change as many people's lives as possible. And what I'm here to tell you is who else in healthcare can treat major underlying health problems and make people more beautiful at the same time. And that's what we, as an interdisciplinary team led by dentists, can do in today's environment and in the future.
Dr. Rick Roblee, really something special to show what's possible and to open up our eyes on the collaboration, really not only interdisciplinary, but the opportunity for us to be transdisciplinary with our medical colleagues on these type of situations where we can work closely together, especially diagnostically, because there's so much lack of that relationship. We know that when we can communicate and collaborate, we're going to improve the lives of our patients. What a terrific case to show. Our team of specialists, any thoughts or questions for Dr. Roblee now that we've seen the complete diagnostics and the final result?
Dr. Roblee, that was an amazing presentation. Thank you.
Thank you.
I can appreciate on the profile picture, it appears that by expanding the maxilla and the mandible moved forward as well and followed. So probably some of that airway relief would come from that mandibular repositioning. Do you think that's also contributed?
I think it's absolutely true. And today, we're using more and more skeletal expansion of the maxilla, which back 6 years ago wasn't really too much. But with that, we're expanding the whole mid-face with the 4-3 expansion. And secondarily, we do get movement of the sutures forward. So you're exactly right. And also with SFOT, we can open up spaces, up to opening implant spaces sometime in healthy relationships to really change the AP dimensions. But in cases like this, vertical cases, especially in female, and let me see if I can go back here real quick. When we look at this is where you see the major occlusion. And that's the angle of the mandible that's opened up vertically. And you occlude all the muscles in the hyoid region to get that occlusion. You rotate that mandible up and forward, it opens this up every time. And so plus, by bringing everything else forward, getting your tongue posture forward, you just get an overall significant improvement of her oral function, in her oral volume. But by the way, the condylar remodeling has been from years of UARS having hypopneic events that she's getting adrenaline dumps all night long, her heart racing, everything else, fractionating her sleep, and then she clenches her tissue. She's been doing that her entire life. That's where you see this significant remodeling with no history of trauma or anything else, in my opinion.
Rick, the airway change, if you overlaid 5-6 years later on a CBCT from back then, which she has breathing through a straw versus bringing that mandible auto-rotated forward, what would that look like if you looked at that scan?
Okay, I actually have it, but it's about 100% increase. And so she went from a 71 to about 150.
Amazing.
Okay. And this area opened up. And again, it's not only about the dimensions, it's about the function and the collapsibility of it. And that's where you can give more. And plus, when we're doing this much expansion, we're expanding it laterally, which is much harder to measure, okay? And because, especially with skeletal expansion of the maxilla, you're expanding the connections to the nasal and oral pharynx and expanding it. So we're really, really understanding this for the first time. And it's exciting and it's game changing.
And we know that obstructive sleep apnea's pathophysiology could be multiple reasons, but about 70% of the time there is an anatomical component.
Absolutely.
So even though we're looking at static images here at an awake patient, we still know that that anatomic component contributes to the condition potentially on a very high percentage of the cases.
Correct. Absolutely.
Well, Dr. Roblee, not only did you expand the maxilla and expand the airway, you're expanding our minds into what are, as dental professionals and specialists, what we have to be diagnosing. And that's what Case Bites is all about, sharing this level of information for everyone to really expand our minds into sleep as relates to medical conditions and how, as dental professionals and diagnostics, we could work interdisciplinary and transdisciplinary with our medical colleagues for the benefits of our patients. What a fantastic case. We can talk about this for hours, but this was tremendous. Thank you, Dr. Roblee, and thank you to our team for the great questions and just really something special. Thank you for what you just showed us. And it shows where we're going as our profession expands itself into healthcare and the relevance of what we do as dental professionals.
Thank you. Exciting time to be a dentist.
You know it.
Thank you for joining us for Case Bites. If you haven't already, please subscribe to this series to receive a new case in your inbox every week.